right, I think it's close enough. Let's get this party started.
Okay. Good morning, everybody. I'm Rose Champagne. I'm one of the nurse practitioners at St. Luke's Hospital through Advocate Aurora. And I'm going to be the moderator today. And today we are very happy to have Dr. Leanne Lau. She has been a board certified general surgeon for over 13 years. And she's currently completing a fellowship in palliative and hospice care at the Medical College of Wisconsin. Today we're going to talk about surgical decision-making in geriatric care, which I think is a very important topic. I think the format that we're going to have PowerPoint with some discussion throughout that Dr. Lau will kind of direct us through. So take it away, Dr. Lau.
Thanks. Good morning. So as Rose mentioned, I'm Leanne Lau, Hospice and Palliative Medicine Fellow at the Medical College of Wisconsin. And today I'd like to talk with you all about geriatric surgical decision-making. I have no disclosures, although as Rose noted, I have been a surgeon for a while in my previous life. So I know that I certainly can't speak for all surgeons, but I do know what it's like to be in the trenches. So I think I have a little bit of a perspective for some of the things that we're going to be talking about. My plan for today, I originally had a few more objectives, but realized that the amount of time that I had here was I needed to be a little bit more focused. So we're going to look at two surgeon-related issues in surgical decision-making for geriatric patients. And while we're going along, I'd like to explore the role of palliative care physicians in that process. And depending upon how much discussion we have, we'll kind of see what we can get to at the end as well. But I'm hoping there'll be some good discussion, so it's okay if we don't get through everything. So why is this topic important? And I suspect I'm preaching to the choir here, but just to review, Americans 65 years and older are the fastest growing segment of the population. Older patients have more social and physiologic complexities and trends would show that they're disproportionately undergoing surgical care. I think we always like to talk a bit about non-beneficial treatments, especially at end of life. And again, this data is based on a review from 2016 that looked at all potentially non-beneficial treatments at the end of life. And it wound up including about 29 studies regarding routine hospital care during the last 6 months of life. It's a little bit limited because, as everyone's aware, the definitions used for non-beneficial, too much, futile, inappropriate, these are a little bit difficult to objectify and codify. And so we're actually going to talk a little bit more about that near the end. But the percentages listed here represent mean values. The ranges between these studies are really variable, but the point I'm trying to show here is just highlighting the scope of issues at end of life care and emphasizing that surgery isn't the only place where potential problems exist. And we know that by having people undergo non-beneficial treatments at the end of life, it's a risk in terms of complications, decreased function, decreased quality of life, and goal discordant care. And in terms of risks to clinicians and to the system as a whole, there's cost, distress, burnout, and resource allocations. So I think everyone in medicine understands that this is an issue. This is data from a 2011 retrospective cohort study in The Lancet that looked at 1.8 million Medicare beneficiaries over the age of 65 who died in 2008. And these are the percentage of patients that had inpatient surgical procedures during the last year of life at 32%, the last month of life, and then the last week of life, which was almost 10%. And not surprisingly, the patients that had inpatient surgeries also had higher numbers of inpatient hospital admissions. They spent more days in the hospital by about 50%, and they had twice as many ICU days. And this is all during the last year of life. So it's not clear that those resource uses were directly related to the surgical procedures, but it's clear that those patients are using a lot of resources. And given the proximity to death, it really is questionable if patients are actually receiving benefit from the procedures, from the surgery, in particular if it's happening within the last month or especially the last week of life. So I think that we can all agree that avoiding non-beneficial treatments would be optimal. And so the question becomes, how are these decisions for surgeries being made in the moment? This is a busy slide, I'm sorry, but I'm actually including it more as a reference. These 3 articles are what I'm planning to use to explore surgical decision-making. And they all do have an emphasis on geriatric populations. But I'll be honest with you, a lot of this will apply to any surgical decision-making. Some of it is probably not geriatric specific. To quickly summarize the articles, the Pitfalls study by Cooper et al. Was a review of the literature on factors leading to communication challenges and non-beneficial surgery at the end of life. And then they used that review to identify some solutions for navigating geriatrical surgical decision-making. The Constructing High-Stakes Surgical Decisions is an offshoot study from the best case, worst case data out of Madison and Milwaukee, which some of you may be familiar with. But in this study, Nabozny and their colleagues looked at best case, worst case scenarios, and they asked focus groups of seniors and surgeons to discuss end-of-life surgeon decision-making. The transcripts were then analyzed for themes about how seniors made decisions and about how surgeons presented treatment options for frail patients. Finally, the shared decision-making article asked academic surgeons questions about acute surgical decision-making, and then Morris et al. Performed thematic analyses of the responses. And I'm not intending to dissect the nuts and bolts of each article. They all have merits and limitations, of course. But what I thought was really interesting was that there are a lot of surgeon and patient quotes throughout the papers. And I thought those quotes would make for a really interesting discussion. So I'm going to try to keep this being relatively interactive, and I'm hoping it won't be too hard on Zoom. And so I was hoping if people are able, I'm going to go through a few quotes. So if you happen to have any thoughts about them, I'm going to give you a minute to process them, to jot them down, and then we can discuss if you don't mind participating in that way. So with that in mind, let's dig in. So this quote, these are all from surgeons. And like I said, I'm going to give you a couple seconds to contemplate each one. I don't think we live in a society in which the healthcare culture is accepting of doing nothing. We tend to err on the side of life. We don't get in trouble for that, whereas we do get in trouble for deciding to withhold certain therapies. I've even had colleagues say, I'm not asking you to make any decisions here. I'm asking you to be a mechanic and do this surgery. And as off-putting as that may be, it is extraordinarily difficult to say no to that. I said, well, the best case scenario is that I get her back to being an end-stage Alzheimer's patient who's completely aphasic and not ambulatory. And they go, oh, we guess we never thought of that.
Well, we've had those patients.
So I just read these 4 quotes. The quote about erring on the side of life, getting in trouble for not operating, colleagues demanding mechanic status, and the patient's underlying conditions seemingly being ignored in the context of a consultation. And so I was hoping we could just talk about this a little bit. And actually, I'm probably going to be jotting down notes while you're talking too. So if you see me looking down, it's because I'm writing as well. But would anybody be willing to share their thoughts about what they heard?
I think that's great, the statements you had, and I agree with all of them, but I would suggest that the problem or the situation is iatrogenic. It's a circular or an ecological. Yes, I think our society is death denying as a whole, and that's somewhat this society, but it's hard to say the chicken or the egg. How much does our healthcare system, because that's what we've put forth to our society, how much does that contribute to that?
Definitely, thank you. There is clearly a societal component. I agree wholeheartedly. And I can't see who's talking. Dr. Wilms, is it? Okay. Anybody else have any thoughts?
This is Maureen with at St. Luke's. All of these, I feel like I've heard all of these myself, and I think maybe this last one, because it's right up here in my face, the last quote, I see sometimes, hospitalists put in a consult for surgery, and I'm like, whoa, this may not even be part of their goals. But the hospitalist wants the surgeon to say no. And they want to remove culpability for a surgery not taking place. So I feel like, we see this, and then, if they have palliative care on board, then we are part of a conversation, but then we're all sort of then waiting for the surgeon to say it's not recommended, So it's sort of a passing the buck down to the surgeon to be able to say no when everybody kind of thinks, why are we doing this? This isn't, but this, especially this kind of patient, let's have a bigger conversation. So none of these are a surprise to me. A lot of these are very common, and it's so unfortunate. So unfortunate.
Maureen, I think that feeds into the other comment, the one about being a mechanic, or, the metaphor of the mechanic, that those two together were really interesting to me.
Yeah, to piggyback off that, Lindsay and I work in a cardiac transplant program, and that's where, you have a group of 30, 40 people making these decisions. And oftentimes you will hear a lot of the cardiologists, or teams saying to the surgeon, well, what do you think about doing this or doing this? And sometimes I think it's the other providers that forget that they are sometimes thinking themselves that they're mechanics, because they'll say, well, I can do that. That doesn't mean, I should, but, all these things you're presenting, sure, they're doable. So it, again, like Maureen said, kind of trying to pass the buck to the surgeon, when really it does need to be more of a shared decision amongst either the team with the patient and family.
I would just comment that it's kind of predictable that we would get here. The default for, at least for my whole career, has been to do everything. And as we have shorter and shorter periods of time to interact with patients, whether it's acute stage or even in outpatient settings, I think we sometimes don't have the relationship depth with patients. And without that relationship, sometimes I think as teams, we forget to ask the patient what they want. And so they don't always know that they have a choice to do nothing. And I think that's mostly on us. We've talked about that recently a lot at Zilber, that it's really important to make sure at every stage that the patient and the family, to the extent they can be, are totally involved in these decisions.
Yeah, and Dr. Turkle, that's a really good point. And part of what I cut out of this lecture was I had hoped that the second half could be reflecting on some of the patient comments as well. These articles are really great. They have some of that, and they're actually removed an entire article that had patient quotes. But I think I'm going to come back to some of these topics. You guys are actually doing a great job of giving my talk for me, which is exactly what I was hoping you would all do. But so I want to go through a few more, and this is really great discussion. And I'm going to open it up again in a minute. So jot down anything you've got, but I want to keep going just a little bit. If a patient's awake, the patient who's actively dying in front of you without intervention, I think it's hard as a physician, and especially as a surgeon, to say no to that. And I'm just going to comment on this one before we go on, because I think this one really speaks to the humanity of what decisions people are facing in general. And this is specific to a surgical decision making, but if you know you can do something, most people are going to try to do that, even if you know the likelihood of success is low. And so I think I liked this quote because I think it really speaks to the fact that surgeons are actually human too. And that they're thinking about these things in that way often. And so I'm going to keep going to the next ones, but I wanted to make that one comment on that particular quote. As much as we internally believe when situations are futile that procedures shouldn't be done, that goes against the grain of the pattern of practice in many parts of the hospital. So I think in those scenarios, I can't really say no to operating. The patient who will not survive the OR. That's a solid contraindication in my mind. I don't think patients should die on the table. Futile would mean that there's no chance that the intervention will alter the outcome, and the outcome is death. I think part of the problem with our definition that way is that there are very, very few things that we can say are 100% in medicine. So it becomes really difficult to say it's truly futile. The catch, of course, to all of this is, who the hell am I? I'm good at what I do, but I'm wrong sometimes. And there's no reason to think that there aren't patients who I think are undergoing futile care who make a great recovery. I've seen it happen. I know it has happened. So I want to talk again. We've got a quote about death on the table as being an absolute contraindication to surgery. And I'd like to know thoughts about that. But also two quotes that are clearly demonstrating the difficulty and murkiness of determining futility. So what thoughts do folks have about those quotes?
The death on the table one was really interesting to me. As Rose has said earlier, the two of us are really involved in advanced heart failure therapies and transplant program here at St. Luke's. And so that one was interesting to me because I can't tell you how many times I've heard patients say, well, I mean, if I die on the table, I die on the table. I think patients sometimes see that as maybe a best case scenario because they know that they won't have to experience some of the symptoms that they fear. But I can understand why from a surgeon's perspective, that would be the one thing that they fear. So I think they're coming from two different sides of the same.
Yeah, and the most interesting thing to me about that quote is that it actually doesn't happen very often at all. It's really uncommon for us to lose folks in the operating room. And so I think that's a disconnect too for patients that, like you said, I think they do think, oh, no big deal. I'm under anesthesia. If I die there, I die there. But we're not usually going to lose you there. We're going to lose you in the post-op period after we put you through ventilation and, post-surgical pain and all kinds of things that are actually rough.
Right. The real question is, what kind of life do you have to live afterwards?
Mm-hmm.
Yeah.
I will admit there's also the jaded part of me that thinks about surgeons and numbers. And it's like, of course, you're not going to take anyone to the operating room that's going to die on the table. So unfortunately, that's something I think about too.
No, and thank you for bringing that up, because that clearly is an issue as well. The idea of the numbers, the 30-day mortality numbers, we talk about those a lot, and I think there's a lot of concern with what happens with those and the perception there as well.
I've got something I'd love to bring up. So some of our palliative folks used it, and some of the quotes used it, which was do nothing. The alternative is to do nothing. Like, we just stop caring for you. We're all done. And reframing those conversations with patients that it's not surgery or nothing. We're going to take wonderful care of you, no matter what choice you pick. But that other alternative might look a little bit different. Comfort care is still nuanced, good medical care. We're doing something for you.
Yes, and I think that's a really nice contrast, Marty, to, I think it was Dr. Turkle who said, that our default is do everything. And so we're really looking at that black and white of do everything or do nothing. And I think palliative care, the whole point is to bring in the fact that there's a middle ground of doing what's right and being comfortable and finding a way to be goal concordant. And so I think that's a really nice point and a really good contrast.
This is Dr. Kersen up in St. Paul. And the thing that struck me about all of these quotes is so many of them are divorced from the patient's goals. You don't know what's behind that. And I'm hoping the surgeons I'm working with or who are helping to care for my patients are reading my notes or having their own conversations with the patients to sort of explore that. Because like for example, I think if they're undergoing fetal care, that is really from a surgeon perspective on this quote in front of us. But that sort of ignores the patient or the family's perspective into this, and that negotiation that is a critical part of this. So that's just a part of, and the other thing that I'll say, and people in St. Luke's have heard me say this, is with the way hospital services are organized now with teams on for 3 days, 4 days, or a week and then off. These long haul patients, we are often the only continuity they really have. And it just makes it even more important to our careful presence in these conversations and with these patients.
Yeah, thank you so much for that comment as well. I think that does speak to an extent, and I agree that these that many of these comments do divorce the patient's perspective from the process happening. And I think I'd like to talk a little bit about some of these. So I've got a little bit less activity now so you guys can put your pens down for a few minutes. But the big thing that I think is important that we've talked about, and I really want to name it here, is this idea of clinical momentum. And this is something I hadn't heard before, but I guess when I heard the term and have really started to think about it, it actually fits with what's really happening. And this is a very, very real issue. The surgeons do feel pressure to operate on multiple levels, but specifically, they feel it from both patients and their families. And I have another quote here where the surgeon says, "I've operated on a patient with a ruptured aneurysm and metastatic pancreatic cancer. I've done it. I told the patient, this is futile, but he said, I'm not ready to die. You cannot make that call for me. I am not ready to die. What do I say?" And so with that in mind, just looking at these studies, on one of the studies, 90% of the surgeon participants noted that they felt pressure from families or patients. But the pressure from families was sometimes in direct opposition to what the patients had stated as wishes. So this is when they were being used as a surrogate. We know that patient understanding of prognosis inversely correlates with aggressive approaches. And so to phrase that a little differently, if patients don't know what's going on, they're more willing to pursue aggressive care. They're also willing to accept lower likelihoods of success. And so I think in terms of how this relates to geriatric surgery decision-making, elderly patients are at a higher risk for having more limited understanding of what's going on. They have cognition issues, they have hearing issues. There's all kinds of barriers that can prevent them from understanding. And then they're also more likely to need a surrogate to help them make decisions, which again can result in more aggressive care being approached. We talked a lot about how the system and society and referring physicians are applying pressure for that clinical momentum. The just being a technician thing, man, I've never specifically been told that. And I don't think it happens quite as often in that overt of a fashion, but I definitely know that the sentiment has been there often. And sometimes you just learn that if you go in and try to have a discussion with certain patients or certain providers' patients, that if you don't wind up coming out with the decision to operate, they're not happy with you. And so you kind of, that's a negative feedback loop that you don't do it next time. Next time you do just go in and do what you were asked to do. And I do think to some extent, this probably depends on specialty a little bit as well. For example, I suspect that orthopedists may more often feel like they're being called in to be a technician. But this literature didn't specifically look at any specialty surgeons. These were all general surgery types of pictures. The other thing that we didn't really talk about, and the quotes don't necessarily get into it well, but the act of consulting the surgeon actually creates an expectation sometimes from the family's perspective that the surgical option is appropriate. And so families and patients often assume that the doctor wouldn't call the surgeon if surgery wasn't a viable option. And because the surgeon is coming, surgery must be appropriate. So by the time the surgeon gets to the room, the patient and family have already accepted the fact that they're having surgery. If the surgeon then begins, and these were some of the quotes as well, but if the surgeon then begins to talk heavily and focus on the potential complications or impacts to quality of life, or if the information that they're saying conflicts with something that the patient and family have heard earlier, they start to question the competence of the surgeon. And so it doesn't necessarily move in a linear fashion like you might think it would in terms of that discussion and decision making. And truly, some of these quotes also showed that if surgical consults for patients are, when surgeons are receiving consult for patients that are clearly awful candidates for surgery, the referring physicians are being held accountable in the surgeon's mind for starting a process that isn't considering the patient's overall health and isn't considering the patient's goals. Again, our societal expectations for surgery, that's the do everything. And in fact, I love that was brought up specifically because I don't know if anybody noticed, but the subtitle of one of those articles was "It's Better to Die Trying." And that one was based on patient responses. And then the final thing, and again, this actually wasn't as powerful as it maybe seems like it would have been, but there's a concern for legal intervention if legal risk if intervention is withheld. And one surgeon did note a quote that if the patient dies, they're not going to be coming back to sue you. The family is the one that will. And if the family feels like you didn't do everything, they may be more likely to pursue legal action. Again, this data didn't look at whether that's true. That's not what these studies were looking at, but it was looking at that perception potentially. So the other thing that some of those quotes addressed was futility. And I just want to talk briefly about that as well, because futility is a form of prognostication. And I think surgeons are just as uncertain about that as everyone is. Like other physicians, they tend to overestimate prognosis. Even the word futility is somewhat controversial, right? We like the idea of non-beneficial, or, there's all kinds of different terminology. And so I think that plays into how difficult this is for everyone. Variability in how surgeons talk about decision-making. Like every other clinician, surgeons have different styles of communicating as well. Some of the surgeons in these discussions felt that they could determine futility for some patients, and then they wouldn't offer surgery if that's what they felt was the case. This actually tracked also with more experience and more support from their colleagues in institution. Surgeons were more willing and able to do that. But other surgeons felt it was more appropriate to share the options, but put a strong bias for their opinion into the presentation. And others just felt like it was their job to present the options and the patient had to decide. And so this gets into the whole kind of distinction between paternalistic medicine versus shared decision-making versus autonomous patients. And I think surgeons struggle in those realms just like everyone else does. Again, elderly patients there is some specific issue with determining what's non-beneficial or futile for elderly patients. They have unique prognostication issues given, all of their other comorbidities. It makes it much more difficult to assess how the outcome is going to look like for an acute problem. Is the patient's heart going to tolerate anesthesia? Am I going to be able to extubate the patient? How long will it take for kidneys to recover? And these are different than the considerations in younger patients. And then finally, nobody likes talking about death. I think even we don't love it. We're probably better at it than most, but I don't think most people love it. So it's often easier to avoid it. And we know this happens with all clinicians by either neutralizing the conversation, offering premature reassurance, or avoiding the discussions completely. And we've seen this happen, and I think surgeons struggle in the same way. And that hesitancy, though, I think bleeds over into discussions about quality of life, pain, cognitive dysfunction, all the other things that we know are important, but are especially important in elderly patients. The papers identified a few other surgeon-related issues, but I guess just to summarize, what I'd like to say is if the patient's going to do poorly either way, with surgery or without, it's often easier for the surgeon to say how risky it is, let them tell you that they want you to operate anyway, and then operate. And on some levels as a surgeon, you're preserving patient autonomy and shared decision-making, and you're recognizing that prognostication isn't an exact science. And these things probably all feel like you're doing the right thing. And it's especially true when you consider that there's this clinical momentum that's in full swing, and the patient and the family are expecting an operation because they think that the surgeon is the only solution to their problem based on what they've been told by their other providers. So I think when you also throw in time scarcity, generalized discomfort with talking about death, and inadequate training in such discussions, right? This is huge, but those items all pave the way to get to the OR, right? That's what they're all kind of helping facilitate. So I have a final quote here. I think sometimes the easiest decision is to just do something about the problem. The most challenging thing to accept is to accept the fact that it's probably futile. I think that's harder. And I think that kind of summarizes the whole picture of where some of these decisions come. So how can we help? And I know I'm getting really short on time, so I apologize, but slowing down the clinical momentum is huge. And I think as palliative care physicians, I know we're not normally the consulting physicians, but the way I think consulting physicians can help is if they really think surgery is not a good idea, tell the patient and the family that. Tell the surgeon that you told the patient and the family that this isn't, that this isn't something that you think is going to be great. Consider a script for how you talk to the patients, right? Mr. Smith, you might have many medical issues right now that are making you sick. One of them is something that we often call a surgeon for. I don't think surgery will wind up being an option for you because of X, Y, and Z, but I'd like the surgeon to come by and give her opinion just to make sure we're not missing anything, right? That sets it up for the fact that we don't think surgery is a great idea. But for our teams, for the palliative care consultants, again, I know we're not the ones normally calling, but I think being aware of the fact that this is happening can be really impactful in terms of how we can assist with the communication where it's maybe potentially gone awry. I think focusing on the fact that it's not just knife happy surgeons or surgeons who don't care. In cases where the surgeon hasn't fully explored potential life limitations or discordance, we got to keep in mind that the primary care team didn't do it either, right? Nobody's done it for the patient. And so it's not just the surgeon. I think our availability to help with those discussions is huge. But we also have to remember that surgeons often have to do these discussions during non-palliative care times. And that winds up meaning that they don't have the support they need. And that the discussions are happening truly at a time that's inconvenient for everybody, right? Families don't want to have goals of care discussions at 2 o'clock in the morning any more than anyone else does, but sometimes that's when they have to happen. Advanced care planning obviously helps. There are some limitations when you're trying to apply that to surgical decisions, but any advanced care planning is better than none. Building bridges. So I will say that surgeons have had an interest in palliative care for a long time. The name palliative care was even coined by a surgeon. So we do care. But I've heard someone describe the palliative care surgery connection or relationship kind of like where oncology and palliative care were 20 years ago or so, where we were trying to like build those bridges and make paths and get inroads. And we worked really hard as a palliative care specialty to make that happen. And I think we need to keep working at it with surgeons and just recognize that there's room to grow. Education is another big thing, and it needs to be surgeon specific. That's one of the big advices in that regard. And then research, quality metrics for futility. It would be great to have some sort of surprise question correlate for surgery outcomes, right? Do you think, and I don't know the right answer, but to actually study do you think this patient's going to survive is probably not the right answer, through 6 months, because we're looking at a week if it's an acute surgical issue. Focusing those metrics also on geriatric populations, and then continuing to study structured communication pathways like we've done for other things, but in specific to surgery decision-making, and then how elderly patients make decisions. So this was the summary in one of these articles, was that although patient, surgeon, surrogate, and system factors all play a role, the type and intensity of surgical care that a patient receives is ultimately determined by a conversation. And that idea, that was the author's idea, that wasn't a surgeon quote, but that idea of everything balancing on conversations is why this topic absolutely should warm the hearts of all palliative care physicians, right? Because that's what we do. So that's all I have. I know we're kind of at the end of time here, but if anybody has any additional discussion points or questions, I'd love to entertain them for as long as Marty will let me stay on the line.
There's also a lot of really good stuff in the chat. If people have not been able to look at that. You know, I have a question, Leanne, about frailty. And we've recently been starting to use kind of frailty scoring for patients. Can you talk a little bit about that in regards to surgery?
Yeah, so actually that's something that the VA also has been looking at. And there is some evidence that making those assessments preoperatively can really be helpful. And the big thing to understand, I think, anytime you're going to try to talk to surgeons about assessing their patients preoperatively, is that you can't couch it as, let's do all of this so that we don't have to operate on your patients, right? Because if you talk to surgeons about not operating, it's a non-starter. You're not going to get anywhere. And what some of the literature out of the VA was showing, though, was that the frailty assessments beforehand didn't actually mean that surgical interventions were reduced by a significant amount at all. But length of stay, quality of life, complications, all of those things, and mortality decreased. And the reason for that, probably, it looks like, you know, looking at what they were doing differently, is that they were getting better pre-op assessments. They were potentially changing anesthetic type to help reduce the risk of intraoperative, you know, physiologic compromise. So, you know, lowering the risks to the heart and the kidneys and all that. And then I think it's the intense focus postoperatively too, recognizing that if a patient is frail, you're going to have to do things differently in order to take good care of them. So I think there's absolutely a lot of utility in it. I think you just have to be careful in how you talk to surgeons about it, that the point behind assessing their patient as frail is not to discern that they shouldn't have the surgery. And again, not that some patients shouldn't, but if you put that as the upfront part, they're going to run away.
There's a question in the chat. How often are chaplains asked to be part of the conversation with patients, families, surgeons, etc.? And are there any plans to add chaplains to this conversation?
That's a really great question. It wasn't actually addressed in the papers that I was looking at. I will tell you that in the centers I've worked at, it depends on the time of day for some places, because chaplains are not always available all the time. When I was a resident at the level 1 trauma center that we were at, the chaplain and social worker came to all of our high-level trauma activations. So I think there is the recognition of the importance. I'm not sure how well it's applied in many cases. But I think it's a great idea.
This is Liddell, the chaplain resident. And the reason I asked is because I got a chance to round with Martin on a couple of patients once. And there's just some things that spiritual care can actually help with, that we can identify, that's not being necessarily brought out by the conversation with the surgeon and or the doctors, especially with family, when the family has the POA, right? The patient is not necessarily cognitive to make these decisions. The family just want the patient, the doctor to do this miraculous, heal them and let them come home. But the reality is not that. And so, I'm just wondering, when is this going to be, maybe mainstreamed into the conversation? Because I think just from what I saw with Martin, it should start to be part of that conversation. And if not chaplains, maybe the family, the clergy, the patient's clergy. But I just believe that spiritual aspect is important for life and death situations and decisions.
Absolutely. That's really well said. And I agree wholeheartedly. And I think that's where surgeons are reasonably good, I think, at the idea of team things in general. they're not always really good at the idea of team things when it comes to communicating, right? They get that they need a team to take care of their patients, to do surgery, but I don't know that it's as well entrenched in their discussion processes. And so I think that's where there's opportunities in terms of education and training to help both learning how to do the discussions, but also recognizing how important extra people can be, chaplains, social workers, all of that. So I think there's a huge opportunity there. And I just saw in the chat, I've made it so I can see it now too, to work through cultural and psychosocial barriers. Absolutely. I think, I think most physicians probably need more help with that in general, and surgeons are absolutely no exception.
Any other questions?
Hey everyone, this is Adrienne Clement calling. I'm a palliative care physician and hospitalist at the VA. I work with Leanne today, actually. Thanks so much for your talk. The one question I have, is there any data about the frequency of the surgeon triggering the palliative care consult?
There are papers about how that looks, and I don't have them at my fingertips to reference, but people do look at it. And one thing I would love to just point out, if I can click back to it really quickly, is where these articles were published. Annals of Surgery and Journal of the American College of Surgeons. And so my suspicion, and some of the other literature I've seen about triggered consults and how that looks either by the surgeon or not, they do see some of the same results as we do in the medicine world. They see some of the same problems too with the idea of triggered consults. One thing I'm super interested in and is looking at more of an embedded model just to see what that might look like. And there's not a lot of research about that in surgical ICUs, but that's something that I'm also very interested in.
All right. Well, this was really great, Leanne. Thank you so much.
Oh, thank you all so much for participating. I really appreciate it. I was a little nervous that no one would say anything.
We're all coming out of our shells.
All right. Have a wonderful weekend, everybody. We'll see you all next Friday.
Thanks, guys.